Hello, our names are Irish, Maria, and Alice, and welcome to our presentation. We will be discussing about evidence-based guidelines in clinical practice for management of laryngotracheal bronchitis, or commonly known as croup. Croup is also known as laryngotracheal bronchitis. It is a respiratory illness that affects the larynx, trachea, and bronchi. The cough and other signs and symptoms of croup are the result of swelling around the larynx, trachea, and the bronchi, which can lead to difficulty of breathing, accompanied by inspiratory stridor and the hallmark of barking cough and hoarseness. Croup is usually mild and self-limiting illness and rarely causes upper airway obstruction, respiratory distress, and death. Croup is common among children 6 months up to 3 years of age, but it can also occur among children up to 6 years old or earlier in atypical cases. Also common in boys compared to girls, and most cases of croup occur in the fall and winter seasons, peaking often in October. Family history of croup is a risk factor. Other risk factors are parental smoking, history of prior intubation, bronchoscopy, prematurity, age younger than 3 years old, GERD, and asthma can also experience recurrent croup episodes of more than 2 times per year. In the U.S., croup accounts for 7% of hospitalization due to fever and/or acute respiratory illness in children younger than 5 years yearly. Approximately 85% of croup cases are defined as mild, self-limiting, and can be successfully managed as outpatients, and less than 1% identifies as severe croup due to signs of hypoxia. About 5% of croup cases are hospitalized, and of those, only 1 to 3% will require intubation. There are a variety of causes, but viral croup is the most common. Viruses are detected in up to 80% of patients with croup, and 75% of them are caused by the parainfluenza virus type 1, 2, or 3. Other viral infections are influenza A and B, adenovirus, RSV, rhinovirus, measles, and enterovirus. But parainfluenza 1 is the culprit during the fall and winter months. The virus infects the subglottic region and the laryngeal mucosa, causing an inflammation and edema, which significantly decreases air movement and can lead to respiratory distress and stridor. Less common causes are bacterial croup, such as Mycoplasma pneumoniae and Corynebacterium diphtheriae. The most common secondary bacterial pathogens include Staphylococcus aureus, Streptococcus pyogenes, and pneumonia. Also, allergies and inhaled irritants and acid reflux from the stomach can also trigger croup. Croup is characterized by inspiratory stridor, barking cough, and hoarseness. Most children typically present with a mild cold symptoms related to a viral infection and a low-grade fever for several days before a loud barking cough becomes evident. As the larynx becomes more narrow, the cough becomes more frequent. The child may have labored breathing or stridor, increased respiratory rate, respiratory retractions, then a barking cough. These symptoms may be exacerbated by emotional distress and are typically worsened at night and can last up to 5 to 6 nights, but the first 2 nights are typically the worst. Spasmodic croup is another type of croup similar to a viral infection, except it is not caused by a virus. It has a tendency to run in families and may be triggered by allergies. Spasmodic croup tends to come on suddenly without a fever, which can be difficult to differentiate from infectious croup. They typically present with mild respiratory symptoms and can recur the same night or for 2 to 4 evenings. As mentioned earlier, most children with viral croup are mildly ill and do not develop significant breathing problems. Among the few who do develop more severe forms of illness, the airway swells enough to interfere with breathing. In rare cases, secondary to bacterial infection of the trachea or bacterial tracheitis can occur after an episode of croup, resulting in trouble breathing due to thick, purulent exudate within the trachea obstructing their airway. They look very sick and respiratory distress with very high fevers and will require emergency care.
In diagnosing croup, the history and physical will differentiate between other diagnoses in croup. The patient may report with a history of early symptoms such as rhinitis, congestion, and coryza, which is the inflammation of the nasal mucous membranes, which then progresses over 12 to 48 hours into a low-grade fever that then lasts about 12 to 72 hours. Although the absence of fever should not reduce the suspicion for croup. The patient may also present with hoarseness, drooling, or difficulty swallowing. Then, as airway inflammation progresses, the patient will then have an abrupt onset of barking cough and the audible inspiratory stridor, which is commonly heard in a child with croup. In the video clip on this slide, you'll be able to hear the sound of the inspiratory stridor and the barking cough. It is common for the symptoms to become worsened by emotional distress, as the child in the video sounds, who is crying and trying to catch his or her breath. This can be an issue because the increased inspiratory effort that accompanies anxiety and fear in the child can exacerbate subglottic narrowing, which further diminishes air exchange and oxygenation. You can hear the father in the video trying to calm the child and telling him to breathe slowly so he can breathe in more oxygen.
Okay.
Upon physical examination, findings may include tachypnea and low oxygen saturation due to poor oxygenation. This is usually noted, though, in patients with more severe cases of croup. Tachycardia may or may not be noted in the presence of fever as well. The child may also become dehydrated due to decreased oral intake and insensible losses from fever and tachypnea. Upon inspection, a patient may be seen with retractions, nasal flaring, or even cyanosis in more severe cases. The most common auscultatory finding is overt inspiratory stridor heard in the neck. If wheezing is present, it is typically mild. If substantial wheezing is auscultated, the provider should prompt evaluation for alternative diagnoses. Rhonchi is also not typical, neither are rales. If either of these findings are present, again, further evaluation is needed. More than 99% of children with abrupt stridor have croup, but the differential diagnoses are broad. The diagnosing of croup is mainly symptomatic. According to the guidelines from the American Family of Physicians, there is no diagnostic testing recommended for suspected croup. The diagnosis of croup, again, is clinical and based on the presence of barking cough and stridor. In the following slides, we will discuss possible differential diagnoses. Differentiating croup from other acute illnesses can be challenging. Distinguishing it from differentials such as epiglottitis or tonsillar abscesses are important because the treatment and prognosis of these conditions are substantially different. Listed on this slide are some of the similarities and differences with croup and the differentials that were just mentioned. With epiglottitis, the patient is 10 times more likely to present with sore throat, to appear toxic with high fever, and have some cough. The child also postures commonly in what is known as a tripod position. Remember, although both are infections of the upper airway, epiglottitis is the inflammation of the epiglottis. With pharyngeal abscesses, the classic characteristics are neck stiffness or torticollis, severe pain when swallowing as well. Onset is gradual with progressive worsening. These patients also present with high-grade fevers as well. Once the diagnosis of croup has been established, the aim of an evaluation of a child with suspected croup is at promptly identifying patients at risk for or patients who present with impending respiratory failure. The key is to prevent upper airway obstruction. This is specifically referring to obstruction of the portion of the airway that extends from the mouth through the length of the trachea and therefore also includes the nasopharynx and the larynx. Rapid assessment includes reviewing the vital signs and assessing oxygen saturations, as well as taking into consideration the general appearance of the child. The general appearance will be scored utilizing a scoring system. The scoring system is known as the Wesley Croup Severity Scale. Although there are a number of validated clinical scoring systems that are used to assess Croup, the Wesley Croup scale has been the most extensively studied and is also recommended by the American Association of Family Physicians. As noted on the slide, the severity scale begins from mild, then progresses to moderate, severe, and then to impending respiratory failure. Again, the general appearance and the findings are scored utilizing the Wesley Croups. In this slide, I've added a picture of the Wesley Croup scoring scale. As you can see, depending on which clinical features the patient presents with, they are then assigned a score. As with the child you heard in the previous video clip of the earlier slide, that child was classified as having a total score of 7 and classified as having moderate severity Croup. He was taken to the ED where he was later administered nebulized epinephrine and dexamethasone. We will discuss treatment later in the upcoming slides. All the points are totaled to result in a severity score. Management of Croup is based on the severity of the illness. Once it has been determined and diagnosed as Croup, the child should be placed in a calm environment where they can be comforted by a parent or caregiver, and should not be repositioned from the posture they have naturally adopted, as this will be the one that minimizes airway obstruction. Ideally, as noted in the pictures to the right, any medical devices like oxygen or nebulizer masks should be held close to the child's face by the child or the caregiver, rather than being applied tightly or administered by a healthcare professional, just as noted in the picture above, as these actions may cause the child to become distressed. In the slide, I also copied and pasted the recommended algorithm according to the American Academy of Family Physicians. As you can see, it is divided into mild, moderate, and severe. Management of impending respiratory failure will be discussed in the next slide. As you can see on the algorithm, the management is similar. Both include pharmacologic and non-pharmacologic interventions. Pharmacologic interventions include glucocorticoids and nebulized epinephrine. These medications have become the cornerstone of therapy. Glucocorticoids provide long-lasting and effective treatment of mild, moderate, and severe Croup. Improvement is usually evident within 6 hours of administration, but seldom dramatic. Epinephrine is thought to improve symptoms in patients with Croup through arterial vasoconstriction in the upper airway mucosa, which eventually leads to decreased edema. The highest severity scoring is 12 and greater, which indicates a child that has impending respiratory failure. The signs of impending respiratory failure include depressed level of consciousness, stridor at rest, severe retractions, poor entry, cyanosis, and/or pallor. For these children, the recommended management setting should occur in a hospital unit. Oxygen should immediately be administered to children with hypoxemia or severe distress. There is a rapid assessment of airway patency and respiratory status to identify those who need emergency airway management. Children who present with signs of impending respiratory failure due to inflammation of the subglottic trachea from Croup will require emergency airway management. Again, every reasonable effort must be made to keep the child calm and comfortable, because anxiety and crying can substantially increase airway obstruction and the work of breathing in a young child. The management generally for these patients includes a single dose of IM or IV dexamethasone according to weight. ICU admission is generally required. Additional consultations with anesthesiologist or an ENT surgeon may be warranted to arrange intubation in a controlled setting.
In 2018, the American Academy of Family Physicians released a guideline for the diagnosis and management of Croup, which was an update from their previous guidelines, Croup and Overview, which was released in 2011, and Viral Croup, which was released in 2004. The guideline illustrates the epidemiology, etiology, and clinical course of Croup, as well as breaking down the diagnostic criteria, differential diagnoses, and the management of Croup. The guideline made 4 key recommendations to implement into practice and used the SORT evidence rating system, which stands for the Strength of Recommendation Taxonomy, to assign a letter grade based off of the quality and consistency of evidence used. The first recommendation was that a diagnosis of croup can be made based off of clinical findings. Radiographic imaging and viral cultures are typically not needed and should be reserved for atypical cases that do not improve with treatment. The primary reason for this recommendation is to avoid delay in care and decrease overall cost of treatment. This recommendation was assigned a C rating, meaning that the strength of evidence was low and primarily based off of consensus, usual practice, or expert opinion. The second recommendation was that humidified air does not improve symptoms of patients with moderate croup. Historically, humidified air has been used for management of croup. However, a meta-analysis found no statistically significant effect on croup scores in patients with moderate croup. This recommendation received a B rating, meaning that the strength of evidence was moderate and was either inconsistent or had limited quality patient-oriented evidence. The third recommendation was that corticosteroids should be administered to all patients with croup regardless of severity. A Cochrane review found improvement of croup scores at 6 and 12 hours after administration of corticosteroids and a decrease in the length of hospitalization and readmission. This recommendation received an A rating, meaning the strength of evidence was strong and consistent. The final recommendation was that epinephrine should be administered to patients with moderate to severe croup. A Cochrane review showed that epinephrine reduced croup scores at 30 minutes. This recommendation received an A rating as well, meaning the strength of evidence was strong, high quality, and consistent. Prior clinical practice guidelines for croup agreed that corticosteroids were the mainstay of treatment for croup. However, they suggested that more research was needed to identify the most effective corticosteroid, the most efficacious dose range, and whether a single dose of corticosteroid was more beneficial than multiple doses of corticosteroids. The updated guideline by the American Academy of Family Physicians attempted to address these topics. In a community-based randomized trial, they found that there was no significant difference between a single-dose dexamethasone or a 3 daily dose of prednisolone. However, they delineated that dexamethasone is the preferred corticosteroid because it can be given as a single dose, it has a long half-life, and it has multiple forms of administration including oral, IV, and IM. Dexamethasone was proven to be superior at reducing croup symptoms as compared to budesonide, and while there was no difference in symptoms improvement between dexamethasone and prednisolone, dexamethasone was shown to decrease return visits and length of stay in hospitalized patients. Additionally, repeated doses of corticosteroids were linked with higher potential for side effects and should be avoided when possible. The guideline continues to identify a gap in knowledge for the optimal dose of corticosteroids, although it did identify that 0.6 milligrams per kilogram was the most common dose used. There continue to be controversies to the approach of croup in the clinical setting despite recent evidence-based guidelines. The following is a case scenario in which a 2-year-old Hispanic male was brought in by his mom with an abrupt onset of barking cough, stridor, and fever for 4 days. A working diagnosis of croup was made by the nurse practitioner. A 3-day course of prednisolone was ordered along with a chest x-ray and a cool mist therapy. Based on most recent evidence-based practice, the chest x-ray was not necessary for a diagnosis of croup. It exposes the child to unnecessary radiation and it increases the cost of treatment. Although cool mist therapy has historically been the mainstay of treatment for croup, there is no statistically significant evidence that it improves the symptoms of croup, and it can increase the cost of treatment for those parents needing to buy a humidifier. Lastly, while a 3-day course of prednisolone has been proven to have the same improvement of croup symptoms as dexamethasone, it requires multiple doses which can decrease compliance. Additionally, dexamethasone is more cost-effective than prednisolone, and it can be given as a single dose, as well as it's been proven to reduce hospitalization as compared with prednisolone. Abiding by most current evidence-based guidelines can help reduce unnecessary diagnostic testing, improve quality of treatment, reduce overall cost of treatment, and improve patient compliance. In conclusion, croup is a common infection primarily affecting children between the ages of 6 months and 3 years old. It is most commonly caused by a viral infection and is typically self-limiting but can range from mild to severe, requiring hospitalization. Most recent clinical practice guidelines recommend the use of corticosteroids for croup regardless of severity and recommend the use of inhaled epinephrine for moderate to severe croup. The quality of evidence provided ranged from low quality to strong, consistent, high quality evidence. The evidence supports implementing the clinical practice guideline into practice because the recommendations clearly outweigh the advantages of current practice.